In Chapter 4, the authors look at systems abroad and compare them to the U.S. system. As we discussed in Chapter 3 of the text, the U.S. healthcare system evolved as a private payment system with a transition to an employer-based insurance system. During the Depression of the 1930s, it became apparent that there was a huge gap in access to health care for those who were unemployed, disabled, or retired. Following World War II, there was much political debate regarding employer based insurance and a government sponsored health insurance. Countries in Europe, such as England and Germany, were already developing different models of single payer systems that covered everyone. In this chapter, we will examine some of the different health system models of other countries and compare the U.S. system to those. As health systems around the world are constantly evolving, some of the material in your text has changed since the text was written. I will try to point out these changes. Two of the predominant single payer systems are the National Health Insurance System and a National Health Service System. It's important to understand how these systems are different and the benefits and shortcomings of each. We'll examine in more detail the systems of Britain, France, Canada, and China, and explore differences and similarities to the U.S. system. This discussion can be especially informative as we consider how the Affordable Care Act might be improved and if the health systems of these other countries provide strategies for improvement. The National Health Service model is a system where health care is provided and financed by the government through taxes. In this system, the government owns most hospitals and private clinics. Physicians may work for the government or have a private practice where they charge the government fees. Other countries that have a similar structure are Spain, most Scandinavian countries, and New Zealand. The National Health Insurance model provides health insurance to everyone through either private or public insurance. Health insurance in Germany is provided by competing, not for profit, non governmental health insurance funds called sickness funds in the statutory health insurance scheme, or by substituting private health insurance. France, Belgium, the Netherlands, Japan, and Switzerland have health systems based on this model. In Canada, the National Health Insurance model relies on governmental universal health insurance administered by provinces and territories, in contrast to the German insurance model that uses not for profit, non governmental insurance. Keep in mind that only developed industrial countries or a small percentage of the world's countries have universal health systems. Some countries like China and the US have partial systems that do not provide universal coverage. The first national healthcare system is also called the Beveridge model, named after the social reformer who designed Britain's National Health Service. The British system was created in 1948 and began with the opening of Park Hospital in Manchester, a government hospital. The National Health Service brought hospitals, doctors, nurses, pharmacists, opticians, and dentists together under one umbrella organization to provide free service for all. The principles for this system were clearly that health service would be available to all and financed entirely from taxation, which meant that people would pay into it according to their means. In Britain, the coverage is universal, although the precise scope of the NHS is not defined in statute or by legislation. So there is not an absolute right for patients to receive a particular treatment. In practice, the NHS pays for preventive services, inpatient and outpatient hospital care, physician services, inpatient and outpatient drugs, clinically necessary dental care, some eye care, mental health care, palliative care, some long-term care, rehabilitation, and home visits by community-based nurses. The British system is funded by general tax revenue, which include employment-related insurance contributions. There's also a private insurance system that includes about 11% of the population that purchases supplemental insurance to receive faster access to some services or access to elective procedures. There is limited cost sharing and out of pocket spending. Persons with low income, the elderly, pregnant women, children, and the disabled have exemption from out of pocket payment. Canada has a system of national health insurance that provides a regionally administered universal public insurance program that plans and funds a system that is primarily private providers. In other words, the government is not the provider of the services for the most part. Funding for this government insurance system comes from general revenue from the federal and provincial governments. Approximately 67% of Canadians also purchase complementary insurance coverage for benefits that are not covered by the public insurance program, such as prescription drugs, vision and dental care, rehabilitation services, home care, and private hospital rooms. There is no cost sharing for publicly covered services, and there's some protection for persons who are low income for prescription drugs, but that varies by region. Insurance coverage must cover first dollar coverage for medically necessary physician, diagnostic, and hospital services, including inpatient hospital medications for all eligible residents. There is no nationally defined benefits package, and decisions regarding services covered are made at the provincial or territorial government level. France has a national statutory health insurance system with all health insurers incorporated into a single national exchange. The French government has an active role in healthcare, allocating funding to various health sectors such as hospitals, ambulatory care, mental health care, and social and health services for people with disabilities. The French universal and compulsory system is provided to all residents by non-competitive statutory health insurance funds. Statutory health insurance eligibility is either gained through employment or granted as a benefit to persons who have lost their jobs but were formerly employed, to students, and retired persons. Citizens cannot opt out of this compulsory system except in rare cases. The state covers the health insurance costs of residents not eligible for statutory health insurance. 92% of the population is covered either through employers or means tested vouchers. The system does include three types of cost sharing: coinsurance, copayments, and balance billing. Many people add voluntary health insurance to cover the cost of balance billing, cost sharing, unusual care, and vision and dental care. Voluntary insurance is allowed only to cover copayments or limited services, primarily those not covered by statutory insurance. There are special provisions to cover cost sharing and out of pocket spending for children and low income people. The U.S. healthcare system has attributes that compare to healthcare systems in other countries. In the U.S., the Veterans Health System can be compared to a national health system, as this system provides universal coverage for veterans through a government system, the Veterans Administration. Indian Health Service is another example of a national health system that provides services explicitly for Native Americans. The U.S. healthcare system delegates responsibility for mental health to states, so states provide mental hospitals. Local municipalities may also establish hospitals, and in some states, these hospitals may be public hospitals. An example of a hospital that started as a local municipal hospital in Oklahoma is Norman Regional Hospital. Private hospitals in the U.S. can be not-for-profit, such as Mercy and Integris in Oklahoma City, but also can be for-profit, such as HCA. In the U.S., 70% of hospitals are nonprofit, with 15% public and 15% for-profit. In England and France, most hospitals are public. In Canada, there's a mix of public and private, with most being nonprofit. Methods of raising revenue to pay for health services are general revenue through the tax system, compulsory payroll tax financing such as Social Security, voluntary premiums assessed by private health insurance companies, and individual out-of-pocket payments. Premiums for health insurance are paid in many countries by employers. National health service systems, such as Great Britain, generally use general tax revenue to fund their system. In the national health insurance system, revenue is often raised through payroll tax. The U.S. is not an integrated system, but rather a patchwork of different systems. In this country, we have examples of most every system in other countries. While we do not have a national health system or a national health insurance system, we do have what amounts to a national health insurance system for older adults, which is Medicare. Medicaid is also similar to a national health insurance system for low-income people. 49% of Americans get their health insurance through their employer, while 7% acquire insurance through the individual market. 19% are insured through Medicaid, 14% through Medicare, and 2% through other public insurance, with 9% being uninsured. Health systems in other developed countries have increased the role of the national government as the provider of health care, either through national insurance or a national health system. China is the exception to this. For many years, under the Communist Party, China had a national health system. That system was dismantled in the 1980s to embrace a private market system. This system created great disparities, especially between rural and urban areas. The current system has increased the role of the government to address these disparities. Payment of providers varies in other countries, with fee-for-service still a primary method in many countries. The national health system in England is an example of a country that primarily relies on capitation. Coordination of care in many countries is limited by the number of primary care physicians. In England, general practitioners provide primary care services and act as gatekeepers for patient access to specialists and to hospitals. In France, a little less than half of the physicians are primary care physicians. In Canada, roughly half of physicians are general practitioners. China has a severe shortage of primary care physicians, and in many cases, services are provided by providers that have vocational training. The U.S. is unique with roughly 1/3 of physicians practicing as primary care physicians. The rest are specialists. There are many parameters to compare the performance of healthcare systems. Many of these parameters lack an approach that controls for variables in different countries, such as cultural context, values, and the healthcare institutions and their structure. The World Health Organization, or WHO, the Organization for Economic Cooperation and Development, or OECD, and the Commonwealth Fund have developed ranking criteria to compare health systems of different countries. Three major criteria have been used to assess health system performance: access to services across income groups, cost, and quality. Countries that have universal or near universal coverage report fewer barriers to healthcare than people in the U.S., especially those with lower incomes. In a 2016 survey of 11 countries, adults in the United States were far more likely than those of other developed countries to go without needed care because of cost. The 2017 Organization for Economic Cooperation and Development, or OECD, report indicates that the total current expenditure per capita in use is $9,892 in the U.S., more than twice the average of other countries. In the same report, the U.S. performance was about average for acute myocardial infarction mortality and colon cancer survival, and was below average for obstetric trauma, a measure of safety. Healthcare expenditures as a share of gross domestic product have not changed much from the 2011 report in your text. The U.S. has gone down 0.5% in terms of healthcare expenditure. France also has decreased slightly, while Canada has decreased from 11.2% to 10.6% of GDP. The United Kingdom and China have both decreased slightly, as has the OECD average. The U.S. still outpaces all other countries. The closest is Switzerland at 12.4% of GDP. The lessons learned cited by the authors of your text are useful for discussion. Can the U.S. get to universal coverage? We have seen this year that the tax penalty for the individual mandate in the Affordable Care Act has been rescinded beginning in 2019. As of a report in April of 2018, of the more than 10.3 million people with coverage through the insurance exchanges, 83% were receiving premium subsidies and 6.3 million enrollees were receiving cost sharing reductions. While these subsidies are still in place, with some states continuing to provide subsidies, their future could be in jeopardy going forward in 2019. The text describes the use of economic evaluation of health technology to drive decisions regarding health expenditures, whether the expenditures generate more benefit than costs. However, the ACA forbids federal government agencies from using cost as a criterion for making coverage decisions. Other countries with universal coverage, such as France, Canada, and England, have used economic evaluation in their decision making process. The text also discusses the cost of healthcare in the United States, arguing that price regulation can lead to reduced costs. Some analysts have argued that if there is more price transparency, consumers have more information and they have more power to make medical decisions, competition will be increased,